Welcome everyone. We're going to get started in 2 minutes. If you want to just in the chat, let us know where you are zooming in from and your role. And I don't know. I don't know if I have anything punchy for this afternoon to share. We'll skip that part because this is a long week of a long year and it's only the second weekend. So just let us know who you are and where you're listening in from today. Welcome, Brandon. I bet it's a heck of a lot warmer in South Carolina than it is in Maine at the moment. Hi, Denise. Hi, Jeff.
Hello.
Hi, Mariah.
Hey, Courtney, I don't know if you saw, but it was 27 this morning when I got
What?
out of bed. So, yeah.
Wow, that's impressive. Okay, I was not expecting that. We may have been about the same today, which says a lot.
Well, we warmed up to about 50, so we're
Okay.
a little warmer now.
That's good. At least we have more layers up here. I think I'm probably better equipped than you are.
I would agree, for sure.
All right, it's 4:32, and we've got a lot of folks. I know people will be pouring in, but we're going to dive right in. Welcome, everyone. My name is Courtney Pladson. I'm the Director of Clinical and Quality Improvement here at the National Healthcare for the Homeless Council. We thought having this discussion today would be important. We have been hearing from folks loud and clear of how challenging the past few weeks have been. We've been working very closely with our federal and national partners across the country and trying to be as responsive to the field as possible, but it's also not easy to get information down to everyone. And so we also know that folks are doing really wonderful, innovative work, and we wanted to create a space for people to be able to share and talk and commiserate and support each other in this space. We wanted to share some of the best information that we're hearing and things that are coming down the pike so you all can share what's happening to inform that guidance. So just to acknowledge, this session is supported by HRSA through the Department of Health and Human Services as part of our award, $1.9 million award financed with non-governmental sources. The contents are those of the authors and do not necessarily represent the official view of nor endorsement by HRSA, HHS, or the US government. And disclaimer, the content opinions expressed in the presentation today are solely those of the presenter, not necessarily those of the council. So with us today, we have folks from across the federal government and national partners. So we have folks from HRSA, from the Veterans Affairs Administration, US Department, from HUD, from USICH, the US Interagency Council on Homelessness, HUD, National Alliance to End Homelessness, and others. And the reason why we meet as a group every Thursday morning, we've been working hard throughout the entire pandemic to be as collaborative and really do as much teamwork as possible because we know that not any one entity holds all the information. So we've been trying to be as collaborative and work together closely. And in those sessions every Thursday, we said we need to hear from the field. We are hearing so much information around the challenges right now with isolation and quarantine. So we wanted to just have this conversation. And the council and the other groups represented here really wanted to hear from you all about what you're experiencing and what you're seeing on the ground right now. So what we are hearing and what you all are experiencing and what I know I am experiencing here in Portland, Maine, is that we're in the middle of the worst surge thus far in the pandemic. We know that there are critical staffing shortages across all sectors. We know that there are fewer resources across systems around health, social, and housing systems. I also know that we're struggling in education systems, and when we don't have education and we don't have childcare, that makes staffing even more difficult. And needless to say, that stretches us personally. We know that INQ sites are at or over capacity. We know that many counties and cities have phased out some alternative care sites and isolation quarantine sites. So that is, we have the highest need ever, and we have some of the lowest capacity ever. We know that many staff are out sick themselves with COVID due to exposures. And then those who will remain are so overwhelmed, exhausted, and burned out. And then we've been hearing a lot of questions and confusion around current isolation quarantine guidance. So just wanted to name it, put things out there of what folks are experiencing. This is a short list and there's so much more, but just also wanted to name and identify what we're all feeling and experiencing. And one of the things that David Canavan highlighted today was asking, is it that we need, is it resources? Is it more guidance? Is it, and it's everything. And it's also, everyone's just so overwhelmed and at capacity and everyone is doing the best they can. It's not that folks are disinterested or not trying or aren't doing their best. It's that everyone is doing their best with so little resources right now. And so I just want to acknowledge that people care so deeply and are working so incredibly hard, especially for our unhoused community members. So I know that everyone on this call, it is a top priority and people are just working so hard. So wanted to ask a few quick polls to get a sense from the room what folks are experiencing locally. Katie, do you mind launching those polls for us? So there are 6 total questions. If folks could just jump in, we have a question of who's in the room. If we have GOC or homeless service providers, healthcare providers, and HCH or federally qualified health centers, local and state government, federal government, or others. Second question is, are you experiencing staff shortages due to isolation quarantine policies to the point where services are currently limited? Does your community have sufficient INQ sites for people experiencing homelessness? Are congregate settings in your community now having to isolate in place? What we're hearing more and more right now, every day. Or shelter/INQ providers, how many days are you asking clients to isolate at your program if they are COVID positive? 10 days, 5 days, varies, or unsure? And then finally, do you require a negative test prior to releasing clients from isolation? We're going to give this just 30 more seconds, let people go through all the questions. So far, seeing lots of answers all across the board. 30 more seconds, Katie, and then you can close out the poll. All right, we have about 45% of folks representing from FQHCs, local state government, 24%, COCs, homeless service providers, 21%, and federal government, 17%, and others, 2%. So really a great representation across our community partners.
I just shared the results, so everyone should be able to take a moment to see who you are with and what people are facing as their tension points.
So who's in the room? We've got a broad representation. For question 2, are you experiencing staffing shortages due to isolation and quarantine policies? 42% yes, seriously limited, and yes, somewhat limited, 31%. See, does your community have sufficient INQ sites? 71% said no, 22% unsure. Number 4, are congregate settings in your community now having to isolate in place? And 66% said yes. This is why we wanted to have this conversation, so we could really, this is the first time we are hearing this across the entire pandemic, make sure people have as much information as possible to respond appropriately. Question 5, for shelter/INQ providers, how many days are you asking clients to isolate at your program if they're COVID positive? So it's across the board, 37%, 10 days, 14% 5, 14% varies, and 36% unsure. And then lastly, do you require a negative test prior to releasing clients from isolation? 15% yes, 36% no, 15% varies, and 34% unsure. So really all across the board. All right, thanks, Katie. All right, before we dive into our discussion, just wanted to let you all know of some current and upcoming guidance or other resources. So our CDC partners updated the isolation and quarantine guidance last week, as many of you know, and shared that. And I'm sorry, one of our partners just add that link to the chat, make sure folks have that. And they recommended for folks in congregate settings that the isolation time remain 10 days with lots of caveats there, but additional guidance will be coming on that as well, because we know that that is a huge challenge. Also wanted to share that the CDC is having a webinar next week, the 20th, specifically around quarantine isolation for correctional facilities and homeless service sites, so congregate settings in particular. So they'll do a deeper dive on this guidance next week. Marcia, just wanted to see if you're here from USICH just to share the guidance that will be coming, I think, out this week. So I'll turn it over to you.
Yeah, thanks, Courtney. Hello, everybody. Good afternoon. So as Courtney mentioned, USICH has been working with CDC and HUD, along with getting some input from other federal partners to just provide some clarifying guidance around isolation and quarantine, particularly in relation to the Omicron variant. And provide some guidance around just some strategies that homeless services providers can be putting into place now. We are wanting to get the input that is going to be received in this listening session to make sure that it is reflective of all of the great ideas and needs that you all reflect today. And hopefully we'll get that out the door and published by early next week.
Thanks, Marcy.
Yep. Thanks for having us.
David, TI team, I'll hand it over to you to share what's coming from HUD in the next few weeks.
Sure. And like all of the partners on the call today, we really want to be amplifying the messages and bringing the content out that can support all of you on the front line that are doing the work day in and day out. So if, as we go throughout today and in office hours on the HUD side and in any forum, really, you have things you need, we want to hear them. We want to be doing everything we can to be supporting your work. A couple of pieces that will be coming out either this week or next week. We're looking at shelter in place guidance, and this is really synthesizing some, if you were on HUD's office hours on Friday last week, synthesizing the material that was presented there into a little bit more of a digestible format and to give some of the key decision points. I think on the HUD side, we're not in a place to kind of manage the infectious disease guidance, but in terms of programmatic decisions and how to structure these decisions, we really want to be highlighting those key decision points and supporting everyone in making a decision as we go forward into this new territory. As Courtney said, we've not been in this part of the pandemic response before. And so I think often hearing what peers are doing can be incredibly valuable. Similarly, we are recognizing the very real staffing constraints that jurisdictions are having. Again, as Courtney highlighted, we know how committed everyone in this space is and how much we are driven by the mission that we all come to work on together. And within that context, programs are having to make some really challenging decisions in this moment of balancing critical staff shortages with keeping programs open. And I think as we navigate those decisions locally, and they really do, these are conversations that have to be had at the local level, there is no one way to address this. This is a combination of resources that each jurisdiction has assembled and supports, and we want to be doing everything we can to support that conversation. So we'll be putting out some guidance there. around structuring that conversation and some of the key decision points, again, kind of looking at those really critical life-sustaining strategy services at the shelter programs and what pieces we may be able to let go in this short-term crisis moment. And finally, the booster messaging, just reiterating, and I know this is the choir of choirs with this group, but reiterating that we have to push into the messaging around effectiveness, because we know how much the booster and the vaccinations have lessened the disease burden at a community level, and really are supporting individuals to not have to go inpatient and not have the experience of severe illness or death. And so really trying to, again, highlight that. So you'll see those come out from HUD in the next week. And again, if there's anything else we can be adding, please drop things into the chat. We have team members who are here to listen. Thanks so much, Courtney.
Thanks, David. The CDC and HUD teams and many of the groups represented do technical assistance to individual communities if there are particular needs that are specific to your location. So if there's an outbreak in your area that you are really needing some guidance and support on, our CDC partners did share that they had an email that you were able to send to them directly. David, can you share the way that folks can request HUD TA for their shelters if there is a specific like place-based need or question?
Sure, absolutely. And I'll put the link in the chat. It's through the HUD Exchange, which will be familiar to HUD's grantees. You can request technical assistance through the help desk, the Ask a Question desk, and that way we'll get you connected with the resources that you need.
Thanks, David. Appreciate that. So I am just seeing a lot of the conversations already and people raising a lot of concerns. Thank you for sharing that, David. I see challenges around testing, shelters not accepting new clients, and folks that places that capacity. For the testing in particular and the messaging from HRSA, we'll certainly pass that to our HRSA colleagues and try to figure out what's going on. I know that everyone is struggling to get tests right now, and that is one of the most challenging pinch points for people. So thank you for raising that. I'm going to take down my slides now and try to and ask for people. We're going to open things up. Lots of things are already happening in the chat and people elevating concerns around testing, lack of access to shelter, and just want to see if folks wanted to share what's happening in your city, any strategies that have been successful or really big pinch points that you're experiencing. So I'll just open the floor now for anyone.
I can throw one of the biggest elephants in the room, which was one of your questions, which is how long to isolate people when they have COVID-19 or in a shelter, because that obviously has a significant impact on demand for I&Q hotel rooms and workflows and a variety of other things. So I'm sure different communities are discussing that. And I'm curious, for those that have moved to 5 days, I would assume that's 5 days with no symptoms or improving symptoms and a negative antigen test at least. But I'm curious, especially if there's county public health or any state public health folks, just talking about the science behind that and making that decision and how you've moved that direction.
Does anyone have a response in particular to Jeff's comment around switching to 5 days?
Hi. Hey, Kate. How are you? Hi, everyone. I hope you're well. You and yours are well. Jeff, I think I sent this to you. So California state guidance right now did not make any specifications about shelter. And their guidance does have the 5 days plus an antigen test for asymptomatic individuals. So we reviewed with our health officer that we're currently going to be following the state guidance, and that went through our city attorney as well, Jeff, to be able to see if we could follow that because of the incredible need that we were having for space and not wanting to put people on the street. So that was the decision we made. For now, we're going to be monitoring the state guidance. That had to be set in play with a couple other different factors as well, where we actually are only testing symptomatic individuals, given our testing limit right now. We do know that 69%, it's much more sensitive right now with this particular antigen. And I actually missed our clinical policy review of what we're doing about antigen versus PCR because we're not picking people up. It is remarkable to me that how many people that are asymptomatic and that we're picking them up for the antigen for positive, and then we're not getting it with other folks. Just of note for everyone, we have a very large outbreak in our jail that includes both COVID, RSV, and flu. I'm just putting this out to just warn everyone. We do testing there, but our healthcare for the homeless programs in San Francisco do not test for RSV. So it is making things very complicated. So in conclusion, that's what we're doing in San Francisco. And that has been approved by both our city attorney and our health officer.
Thanks for sharing, Deb. Wow.
This is Catherine from DC. I just wanted to say, in terms of the length of stay, one complicating factor for us is that LabCorp is so overwhelmed that we sometimes aren't getting our test results back for 6 to 7 days. And so we have people coming to the isolation sites with 4 days, 3 or 4 days to go, having been in the shelter positive for their most infectious period. So we're switching over to the public health lab, but the problem with that is that we then always have trouble getting access to those test results. So it's a really tough situation in terms of getting results.
Jolie, I just want to hand it over to you. I know you were waiting a second.
Yes, I'm in Dallas. Our struggles are, our shelters are really at capacity right now and don't have additional space for isolation and quarantine for those that are COVID positive. Symptomatic or asymptomatic. Unfortunately, our county hospital, Parkland, has become that stand-in, but of course they're at capacity as well. And so we're forced to then try to stand up city facilities or church or gym that can operate as a COVID isolation or quarantine site. We're doing the 10 days, actually 11 days there, to the issue of not having enough staffing to then do the testing before they're released from that isolation. That's another one of the things that's being lifted up right now. And our struggle is, the rest of Dallas is at 100% capacity, hotels and convention center venues. And so previously, when we may have had that option before, we no longer have that option right now. And what is then also compounding that, and it's going to be happening this weekend, is the inclement weather shelters that then open up and people have to be tested before they're lent into those temporary inclement weather shelters. But having difficulty trying to find beds and cots and spaces for people to be or hotel rooms for people to be transferred to. So we're really trying to work together. I have to applaud our community partners here, but it just feels like we're struggling alone in this space, trying to make it work and piecemeal it together.
Thank you for sharing that. And I certainly feel the same challenges here around the competing needs around cold weather. Families, our hotels are prioritizing families over individuals because there's just more people to put in one room. And so our programs are being asked to wrestle with some really overwhelming questions, with ones that have no clear answers. Annie, I'll turn it over to you.
Yeah, and so it's kind of interesting because pretty much all of the alternative care sites were cut way back. So I think we have like 12 beds in the entire county. I had my first positive COVID 2 weeks ago, and within all facility, this is a shelter, all facility negative 3 or 4 days before that with that PCR test. So I started testing everyone in our shelter, and I started off with about 20% positive and the remainder negative, and then tested again at 5 days, and more people became positive. They are generally asymptomatic, maybe a scratchy throat or a stuffy nose, and like 3 of all of those that were tested had more significant symptoms. So I retested those that we first tested positive, and that would be day 6, and they were still antigen positive. So even though they're asymptomatic, I can't put them back into the dorm, into the regular dorm. And we've pretty much just cohorted people because we have no other option at this point. I'm not getting really any significant guidance from our county. So, you know, and kind of right now the question is the 5-day rule or the 10-day rule. And, you know, so I just opted to retest at day 6, and I'll retest at day 7 or 8 and see if some of those have converted and we can move them out of the quarantine area and into the other side of the shelter. So it's, yeah, so having some clarity around these rules, and if people keep asking me about doing more PCR tests, and I go, that's not telling me what I need to know in this particular moment. And I don't feel like that is clearly stated in the guidance, because that's the only thing that the county can offer me is a PCR test. And I don't care whether somebody had it 3 months ago. I want to know what's happening today. So that is my ask, is very clear process for the recovery period and the repeating of the Binax in it, you know, or should we just continue it serially until we get a negative? And I have people that need to go to work. I mean, we're in a population, they're working. This is their first time maybe at a job, and they're saving for a house, and to be having to stay quarantined for 10 days, they're going to lose their spot. So we have that as well. Okay, thank you.
Thanks for sharing, Annie. So it sounds like you are isolating in place. You are cohorting folks in the shelter, and you're just waiting until folks, they have a negative antigen test before you move them back into the other location. Okay.
But I have more than 50% positive. So you can imagine the logistics of that are ridiculous. We don't really have the room to do that, but yeah, we're figuring it out. So thanks.
And then at what percentage do you say it's just a full outbreak and we move no one?
Right. So I'll know probably by tomorrow, because I would have retested everybody that was negative at the beginning. So
thank you, Annie.
Mm-hmm.
Other thoughts or experiences? Tom, do you mind sharing in Chicago what you all are doing right now in the shelters?
Yeah, Mary and I were, this is Tom Huggett from Chicago on the west side, and Mary does the north and the south side with Heartland. We were following the Chicago Department of Public Health guidance, and in general, we're doing 10 days of isolation, release back to the general population without a test at 10 days. If testing, rapid testing using Binax now, which does seem to be picking up Omicron according to our guidance, if that test is negative at day 6 and day 7, they can go back to the regular population.
That's helpful. Thank you.
So you, just to clarify, so you do 2 tests, you do serial twice over. Okay, interesting.
Yeah, it has, then both of them have to be negative, of course. And of course, the person has to be asymptomatic. To tell you the truth, it's been hard to get all of those to align. You know, we're seeing quite a few people with symptoms that go on. Even in our staff, we've had people who had symptoms that go on way past a week, and it's been hard to get 2 serial negative tests. So in reality, and we're not really using PCRs, we're using the Abbott Binax Now as our rapid antigen test. PCRs, like you were saying, is sometimes we're getting it back in 5 or 6 days, and that's really not helpful when people are in isolation.
Catherine, you can go ahead.
Hey, I was just wondering what folks are doing about repeat positives, because we're testing so much. So we're doing a combination of the PCR site-wide testing, and then we're also supplementing with the rapid daily for people who either have symptoms or who are close contacts. And really, I think often just as people are coming and going from the shelter, but we are getting people referred back repeatedly for a positive test when they just tested positive 14 days ago. And then we're turning around and sending them right back to the shelter. So we have repeatedly said if somebody has tested positive within the past 90 days and they have no symptoms, there's no reason for them to be retested. And I think, you know, shelters can't keep track of that, but I'm just wondering what other folks are doing around repeat positives in the presence of or absence of new symptoms.
Jonathan, just reading your message in the chat here around guidance that you're looking for in particular.
I'm sure that there are ID experts on the call, but it seems that we're seeing PCR that can remain positive, but not infectious for weeks to months. So I think that's one thing that's why we're kind of relying on perhaps at least the Abbott Binax Now rapid antigen, because there seems to be a little bit better correlation with infectivity.
I just wanted to see if any of our CDC partners wanted to provide any thoughts. I know the webinar next week is going to do a deeper dive on this topic in particular, but just didn't know if Martha or Emily or Ashley wanted to answer any specific questions, if there are any answers that you had currently.
Yeah, don't all jump in at once. Yeah, around the testing, we don't have a lot of recommendation to use testing to get out of isolation. So it's interesting to hear that a lot of places are using that. It sounds like that's maybe coming from your jurisdiction as a recommendation. It does sound like it kind of creates a sticky situation where someone could kind of get stuck either waiting for long results or with persistent positives. And there was a pretty good POCA call today talking about the change in isolation and quarantine guidance. They posted the slides and the recording of the webinar in case you have an extra hour to listen to it. So they talk about it much more eloquently than I will, but I think the antigen, because it hasn't been correlated with infectivity, that's why it didn't end up using, I see Deb, state recommendations. That's why I think it didn't end up in the, end of isolation, how to end isolation recommendations.
Thanks, Martha. David, did you want to share or speak to one of the questions?
Sure, just on number 4, and I'm sure most of you know this, but I just really want to highlight for your shelter partners, they will not be able to implement any kind of precondition for any emergency solution grant coronavirus funded shelter program. There's a statutory prohibition on that. And so I understand that there is a conflict there between a public health direction under public health authority and the statutory federal direction. So what we are encouraging jurisdictions who are implementing that under their public health authority is to clearly order the shelter program to execute that approach. And otherwise shelters will really not be able to kind of self-actualize that approach without it'll put them out of compliance with the statutory language. So they may need, for public health partners on the phone, they may need some very clear public health order to move in that direction. Of course, again, those are ESG CV funded programs, so that's the constraint of that. Thanks, Courtney.
And just to clarify, do you mind just explaining or giving examples of what the ESG CV funding shelters would be, the alternative care sites, or just specific examples that people might not be familiar with?
Sure. The ESG program funds a large number of congregate homeless shelter programs in the country. It is funding that goes to state and local governments, municipalities, and then is further distributed to nonprofit partners. And so we know that's part of the portfolio of emergency shelter programs in any jurisdiction. And of course, there are faith-based and other partners who also fund and sponsor programs. So it's generally a mix of those two types of programs in the jurisdiction. And then of course, we have seen the ESG CV funds leveraged for a variety of additional program models in this particular moment. So for jurisdictions that are using that as a resource, that same constraint would follow the funding.
Thank you. Thanks for clarifying.
Courtney, I'm still just processing all the other questions in the chat.
Mm-hmm. Go for it.
Slow with the chat, but on number 1, what factors should be considered to determine the appropriate COVID-19 testing interval in a shelter environment. I'll stick our testing guidance in the chat. And if you scroll down to table 3, I believe, that kind of it basically correlates with the level of community transmissions. The higher low level of community transmission, the more often you should be testing. If resources allow, it's up to weekly. Is there formal guidance in determining how many positives in a given congregate living environment warrants an outbreak? No, the sort of epidemiologic definition of an outbreak was more cases than expected that correlate by person, place, or time. So, that is depend on the situation. Oh, Emily's correcting me. One case triggers follow-up. So yeah, I don't think we call it an outbreak necessarily, but if you do have one case, that would warrant additional follow-up in terms of testing. Guidance on shelter staff providing at-home antigen testing. I think that means in the shelter staff performing the testing, like doing the swabbing, running the test, and interpreting results. So that one, I think that's good to have a conversation with your health department on in terms of where CLIA waivers are needed for different tests, depending on the test that's being performed. If you're doing it yourself, you collect it yourself, you run it at your own house. You don't need a CLIA waiver for that, depending on how the emergency use authorization from FDA is written. But oftentimes, if someone is collecting it for someone else on their behalf, running it and interpreting those results, oftentimes a CLIA waiver is needed. So that's where partnering with your health department or your healthcare provider to fall under a CLIA waiver umbrella might be needed. So I would talk to your health department about that.
I think that's something important to call out because it does get complicated with these home test kits. If somebody walks into clinic and they're like, oh, let's put you on the schedule. Oh, and by the way, we have this home test kit. Well, are you administering the test kit? You'd argue you're not. It starts to get very gray very rapidly.
Yes, I agree with that. Yeah.
This is Jolie in Dallas. I was hearing the words, but I just want to be sure I get a very clear yes or no. ESG funding means we cannot require testing before entry into the shelter. Oh,
Correct.
thank you.
Benjamin, you can go ahead. Benjamin, you have your hand up.
Sorry, I'm
okay.
getting text messages and calls. So I just wanted to jump in on the CLIA and use of the rapid antigen testings. Here in Albuquerque, New Mexico, kind of in the early days of as soon as rapid antigens became available, we were able to set up a CLIA waiver for one of our shelter sites here. And it's been an incredibly powerful tool for us. We also have extended use of those as some of those rapid antigens have been, we've been able to access the over-the-counter versions for self-testing at smaller shelter sites and other community partners. With that CLIA waiver here in New Mexico, at least, we have to comply with the reporting requirements. And that can be, in our large congregate shelter, we have had, unfortunately, now with our Omicron cases, a large increase in positivity. So we're doing, our testing load has really increased, which means our reporting load has really increased. So just something for all of the shelter partners on here in terms of staffing. If you have that, if you're looking at getting that CLIA waiver, another thing to consider there, what those reporting requirements would be in your state. It's been it's been a powerful and beneficial tool for us, but it's also, there's now some question about how is it still as powerful and with the current Omicron variants. But I just wanted to mention that the reporting aspect of that.
Thank you for sharing that. Any other response? CLIA waiver.
Just I don't know if, Jeff, this was part of your question, but in terms of the availability of tests, I know in some of the conversations that I'm in with emergency management, as they're supplying resources, what has been critical to the request is that the tests themselves are for diagnostic use rather than surveillance, that it was around returning staff to work. And so you're trying to gauge a particular person's particular status in order to send them back into a high-risk environment, as opposed to executing a methodology associated with a broader surveillance testing. So I throw that out there in case others are in those conversations, and that's a useful set of language to use. It may not be given your particular question or situation.
I think it's more that HRSA is pushing out through all the FQHCs, all these test kits. And so we're getting inundated with, well, starting to get hopefully inundated with test kits for just general population. Obviously, we're focused on people experiencing homelessness and our staff. And so you can put it under your CLIA waiver, but if you don't, then you get into these sticky gray situations you got to work through that are healthcare law related.
David, there was a request from Deb Warren around, can you, no, there was someone else asked for specifically the ESGCD program language, the statutory language around not allowing negative or positive tests to prohibit access to shelter.
Sure, and I was trying to type up an individual response to Jolie's question as well. I'm not quite as quick at the end of the day here as I was earlier today. Deb, great question. And I think that highlights exactly the situation that many funded programs find themselves in, which is because this is a fast evolving situation, we're kind of getting crunched between two sets of guidance, well, not guidance, a statutory federal law and the binding direction of the state or local public health authority under its own statutory authority. And so in terms of implementing those testing regimens, just the path that we're navigating currently is that we really ask our public health partners to clearly order their ESG funded programs to use a testing methodology and make a clear distinction that they're using their public health authority to do so. And this is not something that's being activated under a shelter program's own understanding of a situation. And that is really in recognition that denying somebody shelter, particularly at this time of year, is not a zero risk proposition. That emergency shelter in the United States is in the same category as emergency rooms and other life-sustaining activities, and so doesn't have citizenship requirements or other preconditions. And so we want that decision to be, kind of as heavy as it is. We want all of the right partners in that conversation. So I know that is Darlene, my colleague, helpfully put the statutory language in the chat there. So you have the language direction.
Thanks, David. I just want to elevate Tom's point around discussing risk, who is at risk for serious illness. And one of the things I was wondering is if folks are doing anything specific around isolation, quarantine, around risk stratifying folks, around if people are having to isolate in place or there's limited beds for isolation, what is working well? Are people having public health partners that they are well engaged and they're able to find some alternative solutions, or are people finding ways to risk stratify to be able to identify who is really at risk for severe disease right now? I know there's a few different topics there, but just wanted to kind of bring it back to how are we protecting some of the most vulnerable folks in this population? Ben, you want to go ahead?
Within our system of care, we're lucky enough to have non-congregate isolation space. So we have a hotel that we are able to isolate individuals who have tested positive. That is a partnership between the city of Albuquerque and the state of New Mexico. So there are multiple partners there. So there's a MOU that is at play. So we don't have every bed available for people experiencing homelessness. But how we're approaching that, is, especially with our larger load, is trying to prioritize individuals who have high-risk chronic medical comorbidities who are over 60 or unvaccinated to be placed there. And then everyone who is fully vaccinated, younger, or no medical comorbidities. We have dorms at our congregate shelter that we are doing congregate isolation in. With the CDC recommendation for high risk congregate settings, we are having folks isolate for the full 10 days. And we're just always having to kind of evaluate those needs based on that criteria. Sometimes we have multiple folks that meet that high risk criteria, the limited beds, and then just trying to, luckily we have well-experienced medical teams at both sites who can do that evaluation and triage. But we also I do a lot of phone resource for other sites to help them with that differential process. So if you're a site that doesn't have access to that, I don't know if there's any access through state or community partners to help in that decision making. But that's at least how we've been approaching it.
That's incredibly helpful. Do you have, is there a specific screening tool that you or your partners use in terms of the questions you're asked to delineate like that high risk category?
Yeah, it's just decision tools that we've made through the course of this pandemic, and we've been adjusting kind of as we either gain or lose resources or at different periods. The first parts are, the three big pieces are age, medical comorbidity, vaccination status. From there, we also include symptomatology. So if someone is asymptomatic, that kind of puts them in that lower risk category. Also, if there's high constraint or high demand on those isolation beds in the hotel, if we have someone who may have been higher risk before, but is toward the end of their 10-day period, asymptomatic or low symptomatology, pulling them back to that congregate setting to try and free up that space. A big concern for us is not only just the isolation area, but here in Albuquerque, our largest congregate shelter is 30 minutes outside of town. And so EMS transport is a very large worrying consideration for me. I would trying to identify those individuals that are at higher risk of decompensation, having them in town much closer to that rapid EMS transport time. And then with the personnel, with the staff out at the shelter, having a real low threshold, even though in New Mexico, our hospitals are in crisis standard of care and our EMS services are in crisis standard of care, still having that low threshold of making that 911 call, just because of that long transport time. And probably everyone here has seen how quickly individuals can decompensate with this pathogen.
Jeff asked a question, if placing those with high risk of complications in hotel rooms, how do you ensure effective monitoring for decompensation?
So we tried to actually model this on kind of phone or text messaging based services. There was a study that was published, I believe in November, that it compared just automated text messaging and symptom reporting to morbidity and mortality, and had really just, even just an automated service had significant impacts on morbidity and mortality. We haven't based it on that study because we've been implementing this model prior to that, but we have medical staff on site at the hotel for 16 hours a day. We don't have 24-hour medical coverage, but between 14 and 16 hours, we have medical staff there, do twice daily vital monitoring, and then phone check-ins. We have, earlier we had telehealth resources as well, but we found those to not be as well utilized or as effective as just doing that twice daily check and just having that phone where people can, you can call, check in. And I think the question of how are you doing has been incredibly effective for us. It doesn't have to be getting a temperature, OT status, just, that can just asking someone how they're feeling, that can give you a lot of information.
Thanks so much for sharing. And if you are willing to share any of those protocols, I'm sure the group would love to look at that. And then there was a question around sharing the article that you mentioned. If you could share that, that'd be awesome.
Yeah, if I can.
And if you can email it to us after if you don't find it. Yeah.
Okay.
Thank you. We're at 5:20. So I just wanted to see, I know there were some questions about vaccination. Any other pressing things that we didn't discuss yet, and we want things that we want our federal partners to hear, to work on? What are the other things that you need? It sounds like clear guidance around the 5 and 10 days is really important right now, understanding who and the 5 and 10 day line is really challenging, it sounds like. What other things or specific guidance or products can we work on that would be helpful? What to do in the absence of testing? Thanks, Jessica. Go ahead, Tom.
Oh, I wasn't sure. I saw Deb's hand was raised too. I think maybe what would be really helpful is, Omicron seems to be different to us. It certainly seems to, people have different symptoms. People have, people just are not quite as ill. And we're just trying to, here in Chicago, where it's been in the single digits last week at least, trying to balance that. How are we going to make sure that we can keep people from freezing to death outside, from making sure that we protect folks from coronavirus and serious complications. So I think it would really be helpful from our CDC colleagues, how can we look at Omicron in a certain way, and also especially with people being vaccinated and boosted, I think we're going to need to not just say a positive test or a negative test. We're really going to just say what that positive test in the context of the, of that person in general, of their vaccine status, their other comorbidities, and their age in particular. So those are the things that I think that we would be very interested in. And I think probably our city partners would also be continual to be interested in. Thanks.
It feels like right now between cold weather, RSV, flu, COVID, we have so many competing needs, and the ongoing risk of overdose is perpetual. So thanks for raising that, Catherine.
Could I just add to that, if the CDC is going to, or someone from infectious disease, I do very much feel like we are playing under old rules as far as what we consider to be a high risk exposure in congregate settings. That, we are still telling people 15 cumulative minutes over 24 hours within 6 feet, no mask or no mask, right? But it certainly seems to me that this variant is much more infectious than that. And it seems almost a little silly to be saying that to them, but we don't have better guidance.
I think in practice, Catherine, most places, I'll speak for San Diego, but I guess most other places agree. If there are individuals testing positive in a shelter, we're considering the whole shelter exposed. Basically everyone in that area. We're not like, oh, you weren't around John for 15 plus minutes. Like the whole place. It's all exposed.
Yeah, Catherine, that's what we're doing in San Francisco. We stopped doing case investigation. We didn't have a great yield, and we're down staff. So we're considering the shelter quarantine. And none of this feels very elegant. I'm glad that someone pulled out a study, because it doesn't feel evidence-based. And I have my tarot cards half the time I pull those. So I think that we just need to make the best decisions we can. And the thing that's been the magic for us is really close communication with our shelter partners. It doesn't look good. It's been really hard. I've been using as a mantra as our number one goal in San Francisco for public health is that we're focusing on the hospitals, and that we're not sending people to the hospitals. And the second is the health and wellness of our shelter staff. So really that is one of the most concerning things for me right now, is that how quickly the guidance is changing and how much we're having to change, and we're coming every week with new policies. We also found that many of our shelters we thought we could cohort in really had bad air quality, and they couldn't do, and that wasn't the kind of air quality we thought our original inspections. And really what that means for the shelter staff, because that is the trauma that staff are experiencing is going to be more detrimental over the course of time than COVID. So really some of the balance has been around that and how much guidance we have to give. And then I just literally pray to anyone that will listen. And this is not the kind of public health that any of us signed up for. So these forums that we've had has been really helpful. and sharing with other jurisdictions, because we're all kind of just diving in together. So thank you to the council. Thank you, David. Thank you, CDC. And we're just going to make the best choices we can. But that's been the mantra that we've been using: protect the hospitals and protect the staff. And of course, the people that we're serving.
Thanks for naming that, Deb. I appreciate that. David, want to jump in?
Yeah, my question is, we've been up until the last 2 days, we've been able in our area to isolate and quarantine everybody who's positive in the shelters, and up to we've expanded our hotels and our resources up to a certain point, and now we're at overload capacity, and we need to start too late instructing shelters and locations on how to do isolation quarantine on site. And that's where I feel like I'm a little bit behind on that. And I don't know if there's resources out there for folks like Deb and Frisco that have been doing it for the last week and a half. Or are there resources that we can use to help teach people immediately how to do isolation on site at shelters?
Deb, can I say one thing about that real quick, and then you can talk about yours? David, I'm working on, Deb is also on this email chain. I'm working on trying to collect the guidance that exists in local municipalities that are willing to share their guidance and protocols, and then have the council try to bring those together and share that once we get permission. And Deb is one of the folks who developed some of that, so she can talk more specifically about that.
David, we can share, but I have to be honest, what I sent you, Jeffrey, has already changed. This has been like changing every minute. We actually been finding that three different, the red, yellow, and green zone doesn't work. We need blue zone. So I can send you what we have today, and then David, I'll send you something that we'll create differently tomorrow. So that's been how quickly it's been changing.
And then I know on the HUD side, the HUD team, the HUD TA team is really trying to provide this guidance in partnership with the CDC to shelters through the COCs and their ESG funded shelters. So I know that they're going to be talking about HUD office hours tomorrow as well. So I know so many of those shelter partners are looking to you all to provide that guidance. I also know it's a really heavy lift on top of everything else you're doing. So we also want to make sure that they're going to HUD to receive that information, specifically how they can leverage their funding and their partnerships as well. But yes, to Katie's point in the chat, anything that you want to share with us, the things that Jeffrey is collecting, we're going to try to get out to folks as real time as possible, because we know the guidance through CDC takes 4 weeks to go through clearance. And the guidance that was last week is different than this week. So we know that we want to get information to folks as much as possible, as quickly as possible. I know we only have 2 minutes left, but just want to see if there's all the questions that you had put in the chat. We're gonna pull together for our federal partners, and so we can try to provide some specific guidance on that. David, did you have another question? No. Okay. Thank you all for putting those links in the chat. We are gonna, I don't want to overpromise, but what I think we'll do is try to collect these questions, see what we can put together for you. And then as soon as we get all the guidance from everyone, we're going to push that right back out to everyone that's on this call. And we recorded this as well, so we can share it with others. But if folks have any other ideas, questions, please don't feel free to reach out to us as much as possible. So thank you all for coming, and thank you all for sharing your wisdom.
Thank you.